Ms. Kathy go first. Okay, and then everybody else will go in order. Okay, so this is being recorded, so I will ask you to probably come to the front and keep your side conversations to 0 so we can actually hear.
Okay.
And I would say that this is really important because this is an excellent test review. Okay, Jasmine, can you see Miss Kathy right now?
Yes, ma'am.
Okay.
Hi, Miss Kathy.
Hi, how are you? So I had the adaptation lung sound. And what that means is there are respiratory sounds that are beyond normal sounds, meaning that they're abnormal sounds that you shouldn't hear in the lung. And the first sound is stridor. Stridor is an intense, high-pitched and continuous monophonic wheezing or crowing sound. I heard it a lot on the kids that come in our community health center, and it's like sound like that. So it's almost like they're not gasping, but they are. It's like right up here in the throat. Oh, I'm sorry. It's chapter 12 in the fundamentals book, page 144 to 150. And a key thing that I left out, and I should have told you in the beginning, you should listen to lung sounds with your diaphragm of your stethoscope. Okay. You should check 144 to 154 in the little version. The next lung sound I'm going to talk about is coarse crackles. And coarse crackles are loud sounds. You hear it best during inhalation, I'll say, and not relieved by a cough. The next one is fine crackles, and they are soft, high-pitched, and very brief sounds when you're breathing in and not clearing with a cough either. So crackles are not cleared with a cough, whether they're fine or coarse. And that part, that one is on. It's actually a chart that starts on 151. And it tells you the normal breath sounds on 151. And then on 152, it starts into the abnormal breath sounds. The next one is rails, and they're small, clicking, bubbling, rattling lung sounds when you breathe in. The next one is the pure friction rub. That's a low pitch, like gravel creaking sound. It's almost like if you ever heard sandpaper rub over something, it sounds like sandpaper rubbing over the surface. And so you hear that, you can either hear that when you breathe in or breathe out, and it is not cleared with coughing. The next one is wheezing, which is a high whistling sound. You can hear that when you breathe in or breathe out, and it's most obvious and loudest during breathing in, breathe out. And you'll hear that a lot with people with asthma. Really do hear it a lot with them because they get tight, and it's just like it sounds, a whistling sound. That's the way it sounds. In the handout that we got, all the lung sounds, right? It's spelled right out too. I always go to it's a website that I go to. If you type in on the computer lung sounds, you can listen to every last one of them. Every last one. And I think Nurse Sarah has one too that you can actually listen to the lung sounds. I think that's the one. I did try it. Yeah, just make sure you remember your lung fields. Like the right side had 3, that side has 2. And know your landmarks when you're doing the lung sounds. You would never listen to the lungs over top of the scapulars, because that's bone, you're not going to hear anything. You should go like right down the back, this part, right down here to listen and over. So I think that's it. Did I miss anything?
I know you have a question.
Oh, okay, I'm sorry.
Crackles. Is that what goes into the air that, what it's called?
I don't.
That's no crackles.
It almost sounds like popcorn. You know the little, the packing, bubbles that you get in a packing thing? Sometimes if you pop them, it almost sounds like that. To me, and that's my hearing. I don't know, but I have to relate stuff that I actually mess with to remember the sound. So, I mean, I'm in.
No, you are dead on, and that was excellent. Okay, so let's give a round of applause for Ms. Cat. That was great. As she was reviewing, I was checking out the test questions, and she hit like everything you need to know, right? And what I love that she's talked about stridor, right? There is a partial blockage of the patient's airway. You need to notify the healthcare provider if a patient has stridor, okay? Because that is an emergency because the airway is partially blocked. So Ms. Kathy even went the extra mile and told you about, the lung sounds of the fields and all of that. And so that was excellent. So what you need to know also, right? I know this is not med-surg, but when you get to med-surg, you need to be able to understand the different lung sounds, those adventitious sounds. So I'm going to share this with you in the classroom, but we're going to listen to some of those sounds because I think this will also answer Keisha's question on what it sounds like. Because on the NCLEX, there are what's called hot spot questions. And I've seen them also on ExamSoft where they're actually going to play a sound for you. And then you have to determine, okay, this is wheezing, so I know I have to administer albuterol. Okay, so I will post this. This is med students, and I share this all the time. But we're going to listen to, we'll start with Strider. Sorry for the commercial.
Making sure I eat right. She doesn't just make my lunch. The care she puts in makes my whole day.
You're always
Totally
there.
makes that one.
And we're always here. Here for everyone.
Some people, the children have that.
Yes.
Yeah, yeah, they have that. That's right. Like that.
All right, so I think you get the idea with Strider, right? And it's a partial blockage. So here's an example of how a patient can have Strider besides the croup, right? If they maybe aspirate a penny or a marble, right? That happens a lot of times with, your pediatric patients. They shove a little Lego piece up their nose or something, right? And it does, right? And so what Ms. Kathy said is correct because it's in the upper airway. It's not in the bases, right? And so Ms. Kathy even told you about the fact that the right lung, right, you're listening in 3 spots because the right lung has 3 lobes. The left lung only has 2 lobes because it's making space for the heart. So she really broke that down in an excellent fashion. Okay, so let's now listen to wheezing. This is med school. Yeah, and I'm definitely gonna post it.
Oh,
Okay, so this is your wheezing, your asthma, your COPD patient. I would be administering albuterol, right? And I'm gonna reassess the patient afterwards. Okay, crackles, coarse crackles. Okay, so that's your crackles, right? And so this is gonna be like what lung sounds a patient that has fluid volume overload, right? And we're gonna talk about that a little bit more, right? A little bit more tonight when we go into lab. And I know that Mrs. B is gonna talk about it too when we're in lab, okay? When y'all are in lab. But that is good. So definitely take the time to listen to these lung sounds, right? Especially the ones. So let's just do the last one, proof, because that was a question. And that's always a great NCLEX question. And I think this will also answer your question, Susha.
Fibrosis has taken a fair toll on me.
No, I heard that.
So let's talk about retractions for a second. When we talk about retractions, we got nasal flaring, the use of the accessory muscles, and you're gonna really see them working, right? You shouldn't see your patient doing like this to breathe, but that's what you would see in your patient with croup, right? Also possibly asthma, right? Because they're in respiratory distress, okay? So I'm not going to play all of these, but those kind of give you an idea. And again, Ms. Kathy did a fantastic job, okay? One last thing I'm going to link this to, if you are a visual learner, here is my plug. Let's go to, so this link is also in Canvas, so you can totally use this, right? And let's take a look. I like this pictorial because here it is for crew, right? And hopefully, Jasmine, you can see it. And Jasmine, you have access to this Google Classroom, right, with all of these.
Yes, ma'am.
Okay, excellent. So this gives you all of, signs and symptoms. We're looking at the ribs because that's going to show you the retractions, right? And all the other things that go along with it, okay? Any questions? Okay, that was impeccably done. All right, let's go. We're going to start now. We're going to go in order. Olusola, come on up and tell us about your topic.
Good evening, class. Okay. My topic is on the 6 cardinal directions of gaze, and I found it in page 347 in the Lewis Medical Surgical Nursing Education book. So it says I'm assessing the corneal light reflex to evaluate for weakness or imbalance of the extraocular muscles. So in a dark room, I will ask the patient to look straight ahead while shining a pen light directly on the cornea. And the light reflection should be in the center of both corneas as the patient faces the source light. And I will go from the right
to the left, and from the left to the right, and from side to side. So the light reflection should be in the center of both. As soon as I hold the finger, the patient should be able to follow with the eyes, and I'm watching the movement to see if the gaze is fixed. If there is any shaking, that tells me they have nystagmus or strabismus. My finding will be described as deviation of eye movement or position in one or more directions. And the possible etiology or significance is overaction or underaction of one of the extraocular muscles. So the cranial nerves that I'm basically watching will be these three, which is the oculomotor.
Okay, yes. So cranial nerve number 3, and you'll be looking at 2 and 6
The optic.
and 4. Yes, right? So everything with the eyes.
The 6 is the abducens.
Okay, look at you, fancy. Okay, excellent, right? So let me ask you this question. How will the nurse assess the extraocular muscles of the eyes? How, and what did she just talk about?
Going through the field.
The 6 cardinal directions of gaze, right? So excellent, okay? You told them everything that they need to know about that. Excellent, well done. Any questions? So how will the nurse assess the extraocular muscles of the eyes, right? So there's 6 muscles, right, that go with the eyes. So we're gonna use the 6 cardinal directions of gaze, and that's how we're assessing them. So we're looking for nystagmus, right? So if the patient's eye is moving rapidly back and forth, that's something that you can see in your albino patient, right? But again, that's an assessment. And I'm gonna try not to go too much into med-surg because I'm so used to teaching med-surg, but I want you to really understand this because when you go to med-surg, it's gonna make so much more sense for you, right? All right, so that was fantastic. Oh, so, okay. Let's keep it going. Okay, Sinani, let's talk about glaucoma.
Hey, class. So I got glaucoma. Factors when assessing a patient with glaucoma. This was from my med-surg book, page 369 through 372. It has the definition of glaucoma as a group of disorders characterized by increased IOP and its consequences, optic nerve atrophy and peripheral vision field loss. It's one of the second leading cause to permanent blindness in Black people. They do have genetic factors, so if you do have like a mom, dad, or something that has glaucoma, there is a chance that you can still get it. Let's see, the 2 primary kinds of glaucoma is the primary open angle glaucoma. That's the one that's slowly progression. You don't really have any signs or symptoms, or if you do, you kind of catch it too late, but they are preventable. The other one is the angle closure glaucoma. That one is more acute. It comes with signs of pain, redness, seeing blurred vision or like little blurs that go around the room. The primary focus of the nurse is to keep the IOP low enough to prevent patient from developing optic nerve damage. We want to assess the patient's ability to understand and adhere to therapy plan. The goals for the nursing plans would be have no progression of visual impairment, follow the treatment plan, and have no complications.
Okay, hold on, you mentioned IOP. What is IOP?
Yeah,
What's it called?
interoptical pressure.
Okay, excellent. So yes, excellent, excellent, excellent. All right, so I know they're furiously writing that down, right? Because that's important, okay? So, any questions? Because this was fantastic. She gave you a lot to digest. She gave you a huge nugget that you have to swallow whole. Any questions on the glaucoma?
I know.
Could
And
be
it's
also preventable. You can prevent it. You can catch it early. If you do catch it early, it's best to catch it you'll mostly catch it in the angle side, but by then you already got damage because you already got the pain, you got the blurred vision. It's the first one that I forgot, just that quick. Is the most primary one, the one that can cause the blindness. That's the one that you can't catch in time a lot of times because you don't feel it coming. It has no it doesn't have no pain to it. It comes slowly, so by the time you catch it, they already got some nerve damage. Yes.
So what age, group, any age group, like young, like people like 20, 30?
That's
or
a
is it old?
great Dr. Ignacio question.
I like how that sounds, but I'm not a doctor yet, but. I like how
It
sounds.
says that, okay, so the primary one, the one that you get most common, the one that progresses slowly up on you is usually between 22 and 32. No, that's not the age. Oh, that's the IOP pressure. Yeah, I don't know the age.
It's a geriatric condition. It is a geriatric condition. So not now, if it runs in your family, though, of course, that's something that you have to be careful of and wary of, but it's usually a geriatric kind of condition. And also, if the patient has hypertension, they're also at a greater risk because that is the pressure that's inside of the eye. Because inside the eye, we have aqueous humor and vitreous humor, right? And let me just stop because I'm gonna go off on a far tangent because that's what you need to know right now, okay? So that was fantastic. Okay, thank you, Sienna. So let's ask the class a question. So, how would we test for glaucoma? It's a special test we do. It's part of the eye test, right? And you all were doing it when you were actually doing that assessment. I was looking back at the picture and I was like, oh, I'm so proud. So when you ask the patient if they can see something in their peripheral vision, right, that is also a test for glaucoma, right? And when you have them cover up, right, one eye and they cover up the other eye, and that is called confrontation. Write that down. Confrontation, okay? So that is how we are assessing the peripheral vision, and that goes with glaucoma, okay? So excellent, thank you, Siani. All right, let's go to Angel. She's got a lot of information for you that is excellent. Come on, Angel. No pressure, none of us.
Yeah. Right, so I have factors to consider when assessing an older adult in the eye region. So for the MedSurg book that I went into, it's on page 361. I have a little bit of information from each book. So the risk for vision loss is caused by eye diseases such as age-related muscular degeneration or AMD, diabetic retinopathy, which is a lot of older people have diabetes by this point in time, and cataracts. So something to consider is cognitive impairment, like if they have dementia, if they have Alzheimer's, and their cooperation with that, or their mobility. Sometimes if they're not mobile, their eyesight can also start to go more than people that are mobile and do move around. So also, I found that their financial services may not cover eye, like glasses or certain surgeries. So that can also be a factor in if they have the finances to even get eye surgery or get glasses or contacts. So for the next book, the fundamentals, I found in page 570. I found that this is more about the history side of it. If they have ever had eye surgeries, if they have glasses, ask them to take it off. If they need eye surgery, also get the date of their last exam and how frequently they go. Typically at about age, I think it's 65, you need to start 60 to 65, you need to start going every year. So be sure that they're getting their correct eye exams every year. And also ask if they're taking any eye drops or taking any medications that could affect their eyesight, that could lower their pass rate on that test. And then in the Jarvis book, I found on pages 281 to 283, it says no any vision loss or vision decreases with age. Typically, age-related muscular degeneration presents in 19.7% of people over 75. You also want to, while you're at it, especially in elderly, test La Perla, like their eye reflexes, and do the Snellen chart with every eye exam. Let's see, assess for their lazy eye or eyelid drooping. And glaucoma also increases with age, so check their optic nerves for any damage. Also check their family history and if what age their parents started losing their vision and if they have had any eye surgeries. Lastly, their loss, like I stated before, loss of their perception and their compliance issues. If they're not being compliant with the test, you know, they have that dementia going on. That could also, they could not know what you're asking them, or could just say, I can't see it, when they can see it and not comply with you. So definitely take that into consideration.
What page did you say in the Jarvis?
The Jarvis is 281 to 283.
What page was the next one?
MedSurg is 361. Questions, concerns? Okay.
All right, excellent. All right, you know, one thing that I want to mention, you can come up, that's okay. I'm just gonna mention something really quick. Well, actually, two things. Oh wait, yeah, you had the eyes. Okay, I'm getting ahead of myself. I just wanted to give you a visual of what it looks like for macular degeneration. So when we think macular degeneration, central vision, okay? Central vision, glaucoma, peripheral, and then macular degeneration, central vision. Okay, that's what it looks like. A patient, you know, that's what they would see. Okay, all right, come on up, come on up.
Okay, so I had what is the visual acuity test and how is it conducted and what is the Snellen chart? So this is all gonna be in the fundamentals book, chapter 30, page 570. It's like a quick long paragraph. So the acuity test is to test for central vision assessment in distance or near vision. Yeah. So the way that the test is conducted with a Snellen chart. So it's either on paper or a projector like this, and it will have either numbers or letters. Usually if it's a letter, it's gonna be the letter E, and that's to test the patient's vision. So they would have a patient step back 20 feet away from the chart to read it, having one eye covered at a time, attempting to read the chart. So when the nurse or the physician would do this assessment, they will have it done quickly so the patient's not able to memorize it. And then they'll start from the higher letter, which is larger, to the lowest letter, which will be lower. The way that the test is, like the way that they categorize it with normal vision being 20/20, meaning that the patient is 20 feet away, and that's the numerator. It would be 20 feet away, so that's the distance that you're standing away from the chart, and then the denominator is the distance from which the normal eye can read the chart. So for example, like if a patient has 20/40, the 20 is the patient standing 20 feet away and they're able to read what a normal person can read, and then 40 is with normal vision, which you can read 40 feet away. So you can read like double what a normal 20 vision is.
Please, can you say that again? Because
Yeah,
you're gonna see that again.
Okay.
With the distance, that 40, that's what I want them to understand.
Okay, so the 40 would be the denominator, and that's gonna be the normal vision you can read from 40 feet away.
Okay,
From
for
what
the
a
people in the
patient
back,
can read.
right? That's like almost the same thing, right? That you're gonna see again, okay?
And it's double.
Okay, so if the patient has 20/40, so it's 20 on the top, right? And then /40, that's on the bottom, that's the denominator.
That's the
40
distance from which the normal eye can read the chart.
Right, so the distance is 40. So if you see 20/30, it's going to be 30 feet away, right? If you see 50, it's going to be 50 feet away. If you're in my eye exam, you're like 600 feet away, right?
Yeah.
So that's, but you gotta understand that.
Yeah, and then the larger number on the bottom, which is the denominator, the poor the vision. So that's why everyone's like, oh, 20/20 is better vision because you can see, versus like how Ms. Ignacio said, 60, 70, it's poor. So 20 is the number that they would like for you to be at, but if you're further away, it's gonna be low, higher. So that means poor vision.
So if it's 40,
Mhm.
it means 40 feet. I thought
Yeah,
they're standing 40 feet away from the track.
it's, the vision is as if you were standing 40.
Okay. But wouldn't that be good?
No,
you're not
no,
seeing it
yeah, you
anyway on
can't
that
see it.
format.
Like you're at
Okay,
20 feet,
okay.
but you can't see it. So
Okay,
it's not
okay.
grasping. All right, no
Excellent.
questions?
That was
All right.
fantastic,
Chapter
fantastic.
30.
All right, yes,
Reading
yes, yes,
process.
and yes. Here's a question, since we're talking about eyes. What if you shine the light in your patient's eyes and there's an unequal pupillary constriction in response to light? What would your immediate nursing action be? Is that like a big deal or is that okay?
Yes.
Yes, right, so that's gonna require follow-up by the nurse if you see that, okay, yes. Exactly, okay, you all got it, all right, fantastic, all right, let's keep it going.
Mrs. Ignacio, with the flash of the light, that's under like when you do assess the reaction and the reduction.
Oh, so
Is it
that's
that
gonna
part?
be
You know what I'm talking about?
constriction and dilation, right? So we're testing perla, pupils equal, round, and reactive to light, and then the accommodation is this piece, okay? Yes. All right, oh, I was gadding away, okay, this is Shaitavia, but I gave that to Zakia. Zakia, you ready to talk to us about a perforated eardrum and the assessment questions?
I didn't find it in the book.
Okay, so what did you find? Did you find anything?
I couldn't, me and her, and I reached out to my classmates. We
So
couldn't find
this
it in the book.
Here, you wanna use this and talk?
Okay.
Okay, that's okay. We're all here to help. We're all here as a team, so
You can
let's
just talk.
Okay.
I left it for the.
Okay.
Well,
This right. So it does work, sound and sensitive.
okay,
And then this tells you. So this is for information comment code.
okay.
Okay, and then she's got an image of what it looks like, so you should be good. That's it. Help with that.
Okay. A perforated eardrum is a hole in the tissue that separates the ear canal from the middle ear. It may be caused by loud sounds, a foreign object in the ear, head trauma, and middle ear infection or rapid pressure changes, such as from air travel. The symptoms include sharp ear pain that subsides quickly, drainage, ringing in the ears, or hearing loss. Let me see. The signs and symptoms of a ruptured eardrum may include ear pain that may subside quickly, mucus like pus, fear or bloody drainage from the ear, hearing loss, ringing in the ears, spinning sensation, nausea or vomiting that can result from vertigo. So,
Okay, so excellent. Okay, so that's good, Zakia. Okay. All right,
Thank
well, while you're up, why don't you talk about tinnitus? Because that was also your topic, because you mentioned it, and that
Mhm.
can actually go with this, right? So let's talk about tinnitus.
okay.
Maybe you had something else.
Yeah.
Okay,
Yeah.
okay, come on up.
Okay. All right. I had the tympanic temperature. Okay.
Oh, that's right.
For pediatrics, if the child is less than 3 years of age, pull down and pull back, the pinna down and back. point covered probe towards midpoint between eyebrows and sideburns. For children older than 3 years, you pull the pincer up and back.
Say that again, please.
For children older than 3 years old, you pull the pincer up and back.
Okay, yes, write that down, highlight that, star it, tattoo it on your arm, and take it too, okay?
So you pull it, okay. For adults, you pull ear pincer backwards up and out for adults. So for the adults, you pull it backwards up and out.
So items.
Yeah,
And
yeah, backing up.
backing up.
Backwards, up and out.
So the
Got
thing,
it, up and
so
out.
you did a great job, so let me ask you again. So 3 years old and below, how am I pulling that pin up? How am I gonna pull it?
Up,
Down,
and
down,
back.
Down back. Wait, what's it for 3-year-old?
3-year-old and younger,
Oh,
Tell
so
us.
yeah,
You pull it down and back,
okay, understand that, and if
down
you,
and back,
if you have a 4-year-old, right, how are you gonna pull the pin up?
up and back.
Up and back, right? You've gotta understand that, you're gonna see it again.
What
Okay.
did you page?
Oh, page. Let me get it. I'm sorry, y'all. I ain't even get it.
It's okay, you have given us a great bit of information that we will see again.
Okay, it is page 529 in the fundamental. 529 in the fundamental.
And I've seen that kind of question a lot on NCLEX kind of questions, okay? All right, so very good, thank you, Sakia.
But did you know what page you can find Shantae on that we just searched that?
And we couldn't find the page.
Perforated eardrum, thank you, oh, I don't have the page, I'll look it up while, it's going on and I'll get back to you.
Okay.
So with the perforated eardrum, though, one of the things I want you to know is you need to ask some questions, right? If a patient comes in with a perforated eardrum, I need to know, do they have any pain? Do they have any drainage? Because what Zakia was reading, she mentioned a pus, purulent discharge, because that's going to be significant, right? So a patient that has a perforated eardrum or tympanic membrane, they may report severe pain followed by drainage. That drainage tells us that, oh, it popped, and the it being the membrane, and now all of that fluid is leaking out. So why may a patient have a ruptured membrane? Like, okay, yeah, sometimes kids stick things in their ears, but it also could be if a patient has a lot of cold sinus infection, especially a pediatric patient, those eustachian tubes are not fully developed. That is why you have to pull their pinna in a different direction than adults, because that eustachian tube is not fully developed. And so what can happen is the buildup of that fluid can cause the perforation of the eardrum. That is why babies should not go to bed with their sippy cups, because it increases the risk of ear infection, dental caries, and everything else, right? But that is the rationale behind that, okay? But a priority question is going to be to ask the patient, did you have any pain followed by drainage, okay? Now, your tympanic membrane rupture is also associated with infection, change in pressure, right? So going maybe in an airplane, right? That's right, I like how you think, or self-induced trauma. So here's a random story. My daughter, she was probably 2 or 3 years old, and she kept saying, Mommy, my ears are hurting, my ears are hurting. And I said, okay, maybe you have a buildup of wax. So I got some D-Brox, the wax, drops, and I was putting it in. And so 5 days later, she said, Mommy, my ears are still hurting. And I said, okay, I'm gonna irrigate your ears, okay? So, because I've seen irrigation done before, I'm a nurse, I can do this. So I start irrigating her ear, and I noticed something shiny. And then I look, and I said, Erica, did you put anything in your ear? So, like these little crafty little sparkles and stuff. She shoved one of those in her ear, right? And I'm like getting this big shiny purple thing out of her ear. And I'm like, what in the world, right? And so she's fine. She doesn't have any hearing loss. But I was like, she could have really ruptured her eardrum, right? And she has a history of ear tubes. So I was like, oh my gosh, I couldn't believe it. I was flabbergasted. All this time putting these drops, thinking that she had, maybe was wax, but she shoved a little sparkle in her ear. Okay, but you can see that a lot in repeats. All right, very good. I think y'all will be good to move on.
It's calling.
Yes.
Speaking of peaks, can frequent swimming contribute to that?
Yes, they have something that's called swimmer's ear, right? Swimmer's ear. And so when I was in the Navy, we would have, and I was not a good swimmer, so I had to swim like every day until I got it, and I was jumping off that tower. So what they would do is they would have us rinse our ears with a hydrogen peroxide solution to prevent swimmer's ear. Any swimmers in the house? Any athletes that swim? No? Okay. No, nobody. Okay, never mind. But yes, so does that answer your question though? Okay,
So-
fantastic.
So, peroxide do help with my ear?
Yes,
Because my grandma used to put it in my ears a lot,
right, but it's a certain concentration. So I'm not saying that everybody should go home and like start putting hydrogen peroxide, but it's a certain concentration, because hydrogen peroxide is actually very strong, right? It has to be diluted a certain percentage. I think it's only like 0.25%. Right? So be careful. I'm not saying to go rinse your ears, but there is a solution that they use for swimmers. Okay. All right. Excellent. All right. So far it's going great. And the assessment questions. That's what I should be telling you. Okay. I'll come back to it. Let me just make sure. I think we actually already talked about it. Okay. I think we talked about it. But okay, remind me if I don't come back to it. All right, I know you will. Cynthia, let's come on up and talk about tinnitus, please. We won't bite you.
All right, tinnitus. It's mostly the objective. It's 378.
You
In the
said
message. In
it's
the
mostly,
message.
say that again, objective or subjective?
Subjective.
Okay, yes.
Yes, it's mostly subjective. The patient really have to let you know what she's experiencing, what she's feeling. But the tinnitus is also known as ringing in the ear, and is maybe due to hearing loss that result from aging process. For young people, 4 years old can start having it too. And as a nurse, we will observe the patient for decline in balance, and that's from the atrophy of the vestibular structure in the inner ear, and also slowing of the of motor response. And another thing too, the patient can report is feeling vertigo, which is usually stimulated by head movement or dizziness. And the symptom, the patient might tell you that they feel a buzzing in their ear, clicking, hissing, and humming. Only the patient really can hear it. And the cause of it, sometimes it can be due to internal or external environment. And the treatment, you can actively tell the patient so that when they go home to minimize, being in really loud environment, and to decrease their salt intake, and also to avoid stimulants like caffeine and nicotine. Or if none of this help, they can take it a step further and do like some kind of like aggressive treatment with anti-anxiety medication and antidepressant. That's one of the treatment.
So what is prescribed antidepressants like?
They're mostly treating the symptoms, because like how when you live in, oh my God, I can hear. Some people feel depressed about it, like not being normal.
Oh.
So they're basically treating the symptoms of being depressed.
Okay, I have a question, Cynthia. Okay, so what is the sound again?
It can be hissing,
Uh-huh,
humming,
uh-huh.
Buzzing, buzzing,
Say those sounds again. You're gonna see it again.
clicking, humming, and eating.
Okay, excellent. Okay, very good. Okay, excellent. Thank you, Cindy. Okay, very good. All right, who is next?
So tinnitus can lead to syncope.
Yes, so anything, any ear condition, you want to be watching out for dizziness, which can lead to syncope, which is fainting, right? Losing consciousness, right? So, yes, exactly.
Messing up with your inner.
Yeah.
Also because by ototoxicity.
Yes.
Yes, I like how you think. Tell me a medication that can cause ototoxicity. Okay, just
Any mycins. All the mycins.
antibiotic. If you give me the class, I'll be happy. Excellent. I love it. Okay. Y'all are fantastic. All right. Oh, Jasmine, it's your turn.
Okay.
Oh.
No, we're on number 7, I thought.
We just did Zakia and
Zakia.
Cynthia went. So it's your turn, Jasmine. Sensorineural hearing loss, proboscis.
Yes, that's what I have. So I found a lot of the meat of the information is going to be in the Med-Surg book on page 376 and 377. It's just going to break down the information, like the structure of the ear. However, the information pertaining to the sensorineural, also known as the perceptive loss, signifies pathology of the inner ear. So the cranial nerve 8 or the auditory areas of this cerebral cortex. And then I guess is it called presbycusis?
Yes, say
Is
that
that
again.
The presbycusis is a gradual nerve degeneration that occurs with aging and by audiotoxic drugs, which affect the hair cells in the cochlear. How do you say that?
Cochlea. The cochlea.
So some of the reasons that you could lose your hearing would also be for aging, a family history, health problems, certain medications help you with losing your hearing, being around like loud noises for a long period of time. So like working in factories sometimes or doing certain sports. I know like some rappers after a while of doing like certain shows, they lose their hearing. So that's some of the reasons. I found that information though that actually outlined everything was in the Jarvis book on page 319. So that's what I got for that.
All right, that was fantastic, Jasmine. All right, so to highlight, right? So this is gradual nerve degeneration, right? The nerves are breaking down. It happens with aging, ototoxic drugs, like Jackie mentioned, and sometimes it could be their careers, right? So you mentioned the rappers, people that are, maybe working on the gun range, people in the military. I always think of the guys that are mowing the grass, right? And they got those big old leaf blowers, and if they're not wearing their hearing protection, right? So remember, back to A&P, when you talk about the ears, there's hair, right? That's inside of the inner ear, and that actually is what's actually not moving anymore. Those hairs will not move, and so the patient now can have that sensory neural loss, and that's cranial nerve number 8, also known as the acoustic nerve or vestibular cochlear nerve, right? Okay, we are getting down. All right, let's have Nicole. Come on up. Jasmine, that was fantastic. Thank you.
Thank you.
I had assessment findings of COPD and a COPD patient. I found it the first half in 417 in Jarvis.
Okay.
What page? Sorry,
417.
417.
Jarvis.
Mhm. Someone with COPD will present like a barrel chest. Oh, wow, that's so wrong. They have like a barrel chest and they tend to have a tripod position and they use their accessory muscles more to breathe. There's two branches of COPD. There's chronic bronchitis, which is like a long-term cough and mucus that normally will last more than 3 months. And then there's emphysema, which is damage to the lungs and over time, usually by like a pathogen. Wheezing during normal breathing is a sign with decreased breath sounds, like crackles and wheezing is a sign of COPD with clubbed fingers. And then in the med-surg book on 470, they have like a chart that specifies the normal ranges. For which one?
Or a mix of
470. And then a normal range is 94% to 100, but you would probably find a COPD patient oxygen level is like 88% and 75% is severe. Some diagnostic testing you can do is a spirometry, which is to measure the air they take in and the air they let out, measuring lung volume and diffusing capacity. They will put a pulse ox on either the finger or the toe to read the O2. And then just remember that if the fingers are cold or they have nail polish, that it can give you an inaccurate reading. And then arterial blood gas analysis. This measures the pH in the O2 and CO2 in the arterial blood. And you can do a sputum study, and then some x-rays can show like emphysema.
Okay. Fantastic, Nicole. All right.
Don't they have clubbing nails sometimes?
Yeah, they have club
Look
fingers.
at you, fancy. Okay.
And what else I was gonna add? I'm gonna ask something about the CO2 levels. Like, is there like acidosis or the other respiratory? Yeah.
Yes, it is. You are fantastic. That's right. Okay. So the key is know some stuff. Okay. She's fancy, y'all. So this barrel chest. So wait, hold on 1 second. I'm going to talk about a few things and I want to show some visual aids to complement what Nicole so eloquently stated, right? So the barrel chest, right? It's not because they're buff and they're working out, right? But this is the anterior, right? Anterior posterior diameter is going to be the same as the transverse, right? So transverse is side to side. So that's why they shape like a barrel. It's more round, right? So that's what we're talking about with the barrel chest. Okay, and tonight we're going to be, talking about that with the respiratory assessment. So if you are a visual learner, right? If you can learn by this. So I'm going to show you a couple pictorials to help you with COPD. Nicole mentioned that COPD has two branches. It's chronic bronchitis or emphysema. The chronic bronchitis patient is sometimes called a blue bloater, okay? So when I assess this patient that has chronic bronchitis, this is what I'm going to see. Cyanosis, they're going to have hypoxia. Their O2 saturation is probably not going to be between 95 and 100. And like Zakia told us, respiratory acidosis, right? She's so fancy, right? They're going to have an increased hemoglobin. So why would they have an increased hemoglobin? Yes, they have low oxygen because hemoglobin is a protein that binds to oxygen. So the body is saying, hey, I need more hemoglobin, right? So I can bind to more oxygen. Okay, look at you, so fancy. Exertional dyspnea, right? And so smoking, this is your chain smoker. This is usually the patient you see on an oxygen tank and outside smoking their cigarettes, right? Okay. Yeah, so now this chronic bronchitis can lead to right-sided heart failure, which is also called cor pulmonale. So I kind of have to do a little detour, and I'm sorry, y'all, because I do a lot of detours, but I want you to make this connection. So you all do have access to this pictorial, and when you take med-surg, you're definitely going to need it. So I'm just going to talk about right-sided heart failure for a second, because that could be a complication of your chronic bronchitis. So this is when we assess our right-sided heart failure patient, AKA cor pulmonale. This is what you're going to see. Zakia also mentioned the clubbed fingers, right? Those are anybody not know what clubbed fingers look like? And it's okay if you don't.
Yeah, I do.
You do. Who does not? Who's never seen clubbed fingers before? Okay, so everybody's seen it. So your right-sided heart failure patient, they're gonna have fatigue, ascites, round protuberant abdomen. When we talk about GI assessment, that's what we're gonna get into. Enlarged spleen and liver, right? Hep means liver, like hepatitis, right? And then the spleen, splenomegaly, megaly means big. So here is her liver that's like super big and her spleen is really big. She has dependent edema, right? So that means edema of the lower extremity that we will assess, right? Because this is a health assessment class, by pressing down, right? So it's 1 plus, 2 plus, 3 plus, 4 plus, even weeping edema. That means fluid is actually draining out and it's painful, right? So weight gain. So why is this significant? Okay, or what I should say, this patient is going to be on daily weights because of this weight gain. What's the magic number? Because of all the fluid. So the magic number, when we talk about weight gain in a 24-hour period, is going to be 1 liter of fluid, which is 2.2 pounds, right? Because that's 1 kilogram. So if your patient gains 2.2 pounds or 1 kilogram in a 24-hour period, that means they have 1 extra liter of fluid. So where is that fluid going to be? A lot of times it could be down here. Sometimes it could be in their lungs. And guess what? We talked about crackles. So that patient now is in danger because they have ineffective airway clearance because they have wet lung sounds. The lungs are not meant to be wet, right? They're not meant to be squishy and sounding like that, okay? And they also have JVD. When we talked about JVD, we have to be at a 45-degree angle. You can shine the light, see the shadow, right? So that is your complication of being a blue bloater. Now let's go to the emphysema patient, which is the pink puffer, okay? So emphysema is the pink puffer, and I'm going to respiratory, and so this is a cute dragon who has a barrel chest. And guess what? He's got pursed lips because of the pursed lips breathing. What is pursed lip breathing? So they eliminate that CO2 because of the respiratory acidosis. So the patient is going to be in the tripod position. They're going to be sucking in and they're going to be blowing out through their lips that are pursed, like tightly closed, okay? So hyperresonance, remember Miss Kathy, she mentioned that all those sounds and everything, hyperresonance is going to be what we actually assess when we percuss, right? Because the normal lung sound we want is resonance, okay? The orthoptic position, they have to be sitting up or they over the bedside table or over pillows. They cannot lie flat, okay? And all of the other things that go along with it, okay? So, but that was fantastic, Nicole. I just wanted to make sure that I covered that. Okay, let's go to Keisha now.
Okay. So I had the nursing interventions for visually impaired patients and common home hazards for patients with sensory alterations. So, the adaptation for visual loss is a safety concern for patients. They have decrease in the peripheral vision, and visual acuity, and depth perception. So usually patients with visual impairment are unable to conduct their normal ADLs. So nursing intervention will be to eliminate the fall hazards. You can educate the patient and the family to keep the floors in good condition, free from clutter and throw rugs. Arrange the furniture so the patient can move about more freely. Stairwell, it should have a secure handrail and or banister extending the full length of the stairs. A well-lit entrance of the front and back doorway, and also can suggest to the family to paint the edges of the stairs yellow, so they help the patient to see. Oh, sorry. That is on page 1404, the fundamentals book, that's chapter 49. 14, chapter 49.
All right, fantastic, thank you. All right, I'm gonna ask you all a question. You are inside of a patient's home because you are a home health nurse. Okay, tell me, is this good or not so good? The home has hardwood flooring with no rugs. Good or not so good?
Could they slip and fall?
Okay, so there's no rugs.
No,
Yeah.
That's
That's right.
Yeah, because you could trip on it.
Yes, that is correct. So we don't want scattered rugs, right? Rugs are a trip hazard. Okay, so the stairway has a handrail on one side. Is that good or not good? That is good, the handrail, because they can grasp it. Very good. What about if they have electrical cords placed underneath furniture, hidden away neatly? Is that good or not so good? That is good. Okay. So the faucet in the bathroom is not marked hot or cold.
That's bad.
That's not good, right? That's a safety issue. What if there's an uneven walkway to get into the front door? That's not good. Okay, fantastic. So you all are keeping your patients safe. All right, excellent. Okay, Katish, are you up to it? Is it Katisha or Katisha?
All right, so I got this from the fundamentals book on page 944 and box 40.14. And mine topic was patient teaching for patients with hearing aids. So you want to be sure to teach the patient to initially wear the hearing aid for no more than 15-20 minutes and then gradually increase over time up to 10 to 12 hours. Once they insert the hearing aid, then they need to turn it slowly to 1/3 or 1/2 of the volume. They want to listen for, make sure they don't hear any whistling sounds, because that can indicate that it's the ear mole is inserted incorrectly, or it's an improper fit, or they might have wax buildup of fluid. You also not only want to teach your parents, but your patients, but you want to teach their family members too, in case they're elderly, just so they know what's going on. Want to teach them not to wear the hearing aids under heat lamps, or ladies not to go when they go get their hair done. They can't go under the hair dryer. They shouldn't be out in very wet or cold weather with the device in. The batteries last 1 week with daily wear. If they're only wearing it for 10 to 12 hours per day, then it lasts for a week. The ear moles that they have, you should teach them that they need to be replaced every 2 to 3 years. They should continually check the battery compartment and make sure it's clean. Make sure it's closed properly. They need to check the dials, make sure that the dials on the hearing aid device are clean and that they're easy to rotate and that they don't have any static when they're hearing it, when they're turning the dials. They need to make sure that they keep the hearing aid clean. It says that you can use the soft cloth on it, or just go by the manufacturer's advice on how to clean it. And this is especially for your female patients, because we like hairspray and perfume, but you should not put on hairspray or perfume, because that'll make your hearing aids greasy or oily. So when you have it in, they shouldn't spray the perfume. They'll have to do it before they put it in. They can't submerge the hearing aids in water, and they should know all the different places where the hearing aid might have breakdown, and to make sure that they routinely check the hearing aid device. So they want to check like the ear moles, and they want to check the part that goes over the ear. They want to check the the mics and all that other stuff routinely just to make sure that it's not. So we also want to make sure that we let them know that they need to routinely check out with their audiologist. And then it's important for us to make sure that we have them teach back to us so they have an understanding. So a way for them to put their batteries in and how they put their batteries in, how they would check the device. We also want to tell them when they're not using the device to take the batteries out or unplug it, just to keep it. And we need to make sure that they know that if they are hearing static or any distortion or sound, the sound is poor, then they need to report that to the doctor.
Okay, excellent, yes.
I thought that people who, they hearing these all the, all the time, like all day long, they can't do that. They gotta, take them out at some point.
Yeah.
Or what they do to the ear if they, wear it.
So with the it was I did read that there were a lot of side effects to like wearing a hearing aid all the time. So some people get headaches. And what else did I read about it? Yeah, they had headaches, they had tinnitus, a whole lot of different stuff. With wearing it all the time. It was on page 944 in the fundamental book. Fundamental box 40. And I also that was the 11th edition, and I also looked in the 10th edition because I had that book too. And on that the 10th edition book that was page 113. I mean 1312 in the older fundamentals book.
Okay, fantastic, right? So I want to highlight something that she said that's important. They're going to be cleaning their ear canal every day, not weekly, right? They're going to be cleaning that ear canal every day. Okay, and any sounds of distortion they have to report. So page 3 in your MedSurg book, page 379, table 21.2 in your MedSurg book, page 379, table 21.2. That is what I owed you, the auditory system. So that was Shitavia's questions, right? What kind of questions would we ask the patient when we are performing our auditory assessment? MedSurg book, page 379, table 21.2. Shannon's question, what kind of questions would you ask your patient for a neurological assessment? That's on page 1289 in your MedSurg book. Your MedSurg book, 1289, table 55.3. Okay, so MedSurg book, page 1289, 55.3. Those are the questions that you would ask for your neurological assessment, okay? All right, bear with me. I think we... Yes, 55.3. That's Shannon. Questions the nurse should ask when completing a neurological assessment. Okay, we've got 3 more people to go, and then we'll be done. So bear with me, folks. I appreciate it. All right. Any questions on those 2 bits? All right, Minerva May, come on up. You're the next contestant.
Manifestations of patient with a stroke in different area of the brain.
Perfect.
So if you go to 1334 for MedSurg, chapter 57.
1330.
MedSurg, we have the table 57.4, but before we start that, the effects of a stroke vary from person to person based on the type of the severity, the location, and the number of strokes. So each area of the brain is responsible for aspect of function or ability. So like the cerebellum is located beneath and behind the cerebrum towards the back of the skull. So it receives sensory information from the body through the spinal cord. It helps coordinate muscle action and control, fine movement, coordination, and balance. So like if you look at the 57.4 stroke manifestation related to artery involvement, The anterior cerebral, the manifestation is the motor sensory deficit, sucking and rooting reflex, rigidity, gait problems, loss of proprioception, and fine touch. So the middle cerebral is whatever your dominant side will be the motor and sensory deficit, and then your non-dominant side will be the neglect, motor, and sensory deficit. And if you look in page 1336, it's basically telling you like, if your right brain has the damage, the left side is paralyzed.
Well, left side of the body, right?
Yes, the left side of the body. So
So
page
you have to-
1336.
Okay.
What was it?
Measures. Yeah. So like say, right brain damage, then the paralyzed left side.
Mhm.
Then the left sided neglect. And then the left brain damage, the paralyzed right side. So it's just the opposite.
Uh-huh.
And
Yes, that is excellent. Okay, so that is excellent. So you did, and that is a really important concept to understand. Right-sided stroke, the patient's gonna have left-sided weakness, and I'm not gonna say too much more because I'm gonna get into Makaya's topic. If you are a visual person and you're like, okay, it's stroke, right? And something I think Minerva maybe I missed it. Did you talk about the B fast? No? Okay, so we'll talk about the B fast real quick. So this is a visual aid for stroke, right? Again, you have access to it. It's under neurological, right? But it tells us about paralysis. Look at those pupils. They're unequal, right? Again, with the pupils. We're going to see visual changes. Minerva May mentioned something about left-sided neglect. So if you have a patient that has left-sided neglect, they have to turn their head so they can actually see what's on the left side. So if you are the nurse, you need to stand on their good side so they can see you or they can hear you, okay? Fantastic. Okay, let's go to Jacqueline now. All right, Jacqueline, let's do it.
All right, guys. So I can't give you the best page to look at in your book, but one of them that I did use was page. Right somewhere was your med surg books, page 1284. So my topic was neurological injury and how it affects your parasympathetic system. So very quick review of your parasympathetic system and what it is. It's your network of nerves that relaxes your body. So I want y'all to keep in mind, I guess fight or flight, yes. Yes, so it's part of your autonomic nervous system. So you have your parasympathetic and you have your sympathetic. Now your sympathetic is where you have your fight and flight. Your parasympathetic is just going rest. So you can keep this in mind. I'm gonna give y'all a little rhyme, okay? So rest and digest, feed and breathe. That's all you gotta remember. And anytime I ask you a question, are you resting, digesting, or you feeding, or you breathing? Now let's go through the body systems really fast. Oh, can you go to the other one first?
Yes, ma'am.
Yes, feed and breathe, and I'm gonna go over why. So this is what she wants you to remember 9 times out of 10 because you're going to need to use it for your test. So you have salvation. Lacrimation, and she'll probably have this slide somewhere in one of them systems too. And when you think of lacrimation, we're gonna think eyes, and I'm gonna go over that in a minute. Urination and defecation. So while y'all are writing that down, I want y'all to remember in this system, your parasympathetic system, when it comes to your eyes, think of pupil constriction. When it comes to your nose and your mouth, I want you to think about saliva, mucus, and your breathing during your resting periods. When it comes to your lungs, you want to think about your air raid muscles and the reduction in force that you're going to use to go to sleep so you can calm down and sleep peacefully. Then I want you to also think about your heart rate lowering and the pumping reducing. You also doing that during periods of rest and sleep. Your digestive system, it increases. This is the only time you're going to see an increase. It increases the rate of your digestive system so that it can help you divert energy.
So when you think about people with diabetes too, it's gonna pump out more insulin when you need it because you're gonna need that energy to help break down your sugars and stuff like that. So digestion is the only time you're gonna see an increase. Waste removal is gonna relax the muscles for both ends. And then for reproduction, this is when you're going to get your arousal secretion, okay, which you're gonna need in order to physically feel good about sex desires. This is all gonna come from this system, which is very important, right? Because what I'm supposed to be telling you about is when there's an injury. Now, she wants you to understand something called a dermatome. That goes back to the nerves. Now, your book gives you a very precise definition of dermatomes that I didn't even understand, but you can read it. It's on that page. Basically, it's the area of skin supplied by a single spinal nerve. So we think of the body as a map, right? Your spinal nerves, when you come to the cell blocks, this is your map. Every one of these, starting at C2 all the way down to L4 and 5, is your on-ramps to a freeway. Each freeway is going to lead to a specific location, right? So if you have on-ramp T1, it's going to lead to a specific location. If you have an injury at that T1, you can't get nowhere else, okay? Because this highway going to lead to this highway to this highway. If this highway done, then you done. We ain't going nowhere else, okay? It's kind of like the Montgomery Mac and the HRBT. If it shuts down, you just kind of stuck. Now, there's other places you can take, but I'm not going that route to go to work. Be shut down, I'm shut down too. So remember, if anytime you have any kind of injury to any one of these spinal nerves, wherever injury it occurs at, anything that falls below this spinal nerve will no longer work. But when it comes to this parasympathetic system, I want you to remember when you're dealing with patients, right? All you have to remember when we're giving care is Maslow's hierarchy, right? We go through Maslow's hierarchy. Oh, let me tell you something real important too, because I don't know what she's testing on. Your parasympathetic system uses 4 out of 12 of your cranial nerves, okay? We have your ocular, number 3, ocular motor. Your facial, number 7. Your glossopharyngeal, number 9. And your vagus, number 10. The top 3 that I named are your cranial nerves that deal with your senses and your glands. We went over that, we went through the body part. The 4th one is your vagus nerve. That's going to extend down through your neck, to your chest, through your abdomen, and there's also going to be some nerves that go out to, that's going to control that bladder portion, okay? Now, back to Maslow's hierarchy as nurses, what you got to deal with when you have patients that have damage. You go, girl. So this is all you have to think about. Of course, food, water, sex, sleep. This right here is like the basic, because you know you have to come here in order to get to most of these above here. But a person's going to have problem with breathing because they can't rest, right? Depending on where their damage is located, they're not able to slow down and take the rest in order to get some good sleep. Food, they may be able to eat, they may be able to swallow it, but what's their digestion like? So you might need to consider a special diet or things that they need to watch on. Are they checking their blood sugar? Because we never know how it's going to be affected. It's going to be affecting different people. Water, it can deal with the food, but we talked about it being effective to their glands, right? So are they sweating when it's hot? Are they overheating? Those are things that they need to keep in consideration. How much water is this person intaking? Are they able to efficiently eliminate it? Sex, this is going to come all the way through here, because we all need to feel love. We all want to be, sexually desired by our partner. We want to feel like we're giving that same thing back. The person could be in a relationship, got injured, and now nothing's working. They don't even have a desire. It's causing relationships in their home, which is messing up their self-esteem and their feeling for love and all that stuff. Sleep. We all at some point in time need sleep, like now. Or else our body doesn't function correctly. So does this person need to be put on a medication for sleep? Is their blood-brain barrier affected? What kind of medications could they take? It's just all, once you start here, it's going to open up all the questions you need to make sure you're giving safe care to that patient, okay? And basically, that's all you really need to know, guys. Was there anything you wanted to add?
No.
right.
Okay, drop the mic and walk on. Okay. All right, any questions? She gave you all a lot of information that was actually really excellent, really excellent. Okay, really excellent information. Okay, and so, I do want to just emphasize something to make sure that you got it. So when she mentioned, right, that parasympathetic nervous system, right? When it's activated, you're gonna see this patient, they're gonna have increased salivation, they're gonna have increased lacrimation, right? They're gonna have increased urination and defecation, right? I feel like Jesse Jackson right now, right? So the thing is, and if you have difficulty remembering, right, this cholinergic, remember anticholinergics, they dry everything up, right? So it's the opposite. So when you have that parasympathetic nervous system that's stimulated, you're gonna have all of this excess, okay? Questions? All right, that's all right. Let's see, Micaiah, here you go.
This is in the Jarvis book on page 672. So. Or what page is Jarvis? 672. So it says, the fee is at the bottom of table 24.4. Decreased or loss of motor power caused by problems with motor nerve or muscle fibers. Causes are acute trauma, spinal cord injury, stroke, and polyneuritis, Bell palsy, diabetic, and a pattern of paralysis is hemiplegia. Am I saying that right?
Wait, you're paraplegia and hemiplegia.
Hemiplegia. At the top in 24.3, it defines paralysis.
Paralysis.
So what this has to do, the hemiplegia is the right or left side of the body extremity is paralyzed, right? And the paraplegia is the lower extremity, and then the quadriplegia is the four extremities, so from the neck down. And then on page 677, same book, it goes a little bit more in depth about hemiplegia. So the person might have weakness in their lower muscles, if this is the hemiplegia, or a loss of hyperreflex. And paraplegia, they might have lower motor neuron lesions, so caused by the spinal cord injury, and no movement or reflex activity below level of lesion. So that was pretty much like what I got on it, and then I had Google.
That hyperreflex you mentioned, is that when you can see a certain part of the body just going off by itself?
Yes,
Because I've
right,
seen
like
that in a paraplegic before. I've
Right.
seen it in her legs. I mean, the legs didn't work, but they was like,
Yeah.
oh, like, yeah.
Yes, absolutely. And so what else did you want to, and that's a great question, Jackie. What else did you want to share with us?
So this is a good thing. I saw, I had seen it in the beginning of this, it's in the same book. So it's on page 666 at the bottom. It's called FAST. So this has to do with stroke, but it's dealing with this too. So F stands for fast droop, face drooping, sorry. A says arm weakness, S is for speech difficulty, and T is time to call 911. So if you know, so symptoms that you can notice if they're having a stroke or having issues with as far as like hemiplegia and paraplegia is if their face is drooping on one side, they're stuttering,
Got it.
Some things to help with it is like a brace or mobility equipment like wheelchair. I think that's about it. I'm kind of everywhere.
Okay, no, you hit the spots. You did fantastic. Okay, so excellent. And so be fast is something that I was going to talk about with Minerva May. So you hit it right. That's something that you need to know. Okay, there's I think a few other fine points, and then I'm going to let you go. If you have lab with me, I think we're just going to stay down here to save time. All right. So the last few things, just to mention, if your patient has a neurological injury, when we think about the sympathetic nervous system, things are going to dry up, right? So that patient will have like a decreased urine output, decreased salivation, right? The opposite of the parasympathetic nervous system, right? That Jackie so eloquently talked about. Okay, other things that you need to know. Okay, you talked about the hemiplegia. Let's just talk about GBS for a second, Guillain-Barré syndrome. So with GBS, right, with GBS, what I need you to know is that is a condition with ascending paralysis, okay? And this is a great pictorial. So with GBS, one of the things that we have to do is a lumbar puncture at the bedside, okay? And so with GBS, the ascending paralysis means that it starts at the feet and it works its way up. I am really scared because that muscle weakness is going to go and affect their lungs, and then they won't be able to breathe, right? That's the significance. But the test that goes with this is a lumbar puncture. And we are looking at cerebrospinal fluid. I know that cerebrospinal fluid is not supposed to be cloudy. If I get it, that's right. It's supposed to be clear and has positive for glucose, right? So if your patient's lumbar puncture, the CSF, cerebrospinal fluid, is cloudy, that is an abnormal finding. Okay. Yes, excellent. So another question, if your patient is a geriatric patient, one of the things that goes with aging is going to be the increase of their blood pressure, right? Because of the decrease in the elasticity of those blood vessels. So it's going to be harder, right, for the heart to actually pump blood efficiently through the body. So they're going to have that increased systolic blood pressure. That is an effect of aging. If you have a patient that is a smoker, what's going to be some of the things that you have them do? What would you teach them? Stop smoking. So you wouldn't say, stop smoking or you're going to die. You would teach them about smoking cessation, right? And how to gradually decrease and, introduce a nicotine patch, all of those kinds of things. All right. I think you all have done a fantastic job. And I want to get some feedback from you all. Do you think that this was effective or not so effective? It was effective. Okay. Yeah, because, all right. So half and half, right? So, Yes, well, and I'm talking about just for lecture, because sometimes you have teachers that, okay, they just stand and read the PowerPoint. Sometimes you have different things, but I'm trying to appeal to all learning styles. So if you don't love this, I won't do it every single time. I can mix it up a little bit, right? We can play some Kahoot, we can do some other things, but I'm just trying to, because it's late, it's, it's a long class, and then you got lab after. I'm just trying to do something that is, beneficial. Interactive.
I think I really enjoyed this round because it gave an in-depth discussion on each different thing that was touched on. So when you were in this class, it kind of like it touched on every single thing that we might see on the screen. So it was kind of
Okay, awesome. The thing that I love, oh yes, Sienna. Okay, all right. So the one thing that I did love, and it just really made my heart so happy, is you all were getting into your books and highlighting and taking notes. And I love that, because that is going to be a skill that you're going to need to take with you for your future classes. All right, so that is the end. Those of you who have a lab with me, stick around. Let's take a 10-minute break, and we're going to jump into the respiratory system. For lab, you definitely need your stethoscope today. I'm gonna get some alcohol wipes, and we're gonna go with the Jarvis book. Okay. So if you need to like decompress, take some handouts with you if you want them. Definitely take the one with the respiratory assessment. Jasmine, go ahead and take a break, and we'll reconvene in like 10 minutes. Okay.
Okay.
Thank you. Yes, I'm gonna get the book. You don't know where your book is? Oh my goodness. Oh my goodness. Okay, let me just plug this in, because Jasmine is gonna be with us.
Hey, Jasmine.
Oh wait, let me stop the pause.
Hey, I can hear you.
All right, so, and I'll let you face the class because you'll be talking through with someone, or you'll be just observing. All right, so we're in Jarvis, chapter 19, page 405. So this, these landmarks, right? We really need to be familiar with these landmarks. So that's one of the things I really love about this textbook, right? So we have our anterior landmarks and our posterior landmarks. So anterior being the front, and then posterior being the back. We also have to remember our lateral lung sounds. So what I want you to make sure that you are listening to when we talk about the auscultation and where you're going to be placing your stethoscope, go to page 419. Okay, page 419. Okay, so that's the percussion. Let's go to the auscultation part. To 419 and page 421. Okay, I think that was also a test question. Vesicular sounds, I think, on the lateral part. Okay, okay, let me. Yeah, that is, I think, one of the questions about breath sounds. All right, so 419, page 421 shows you the actual locations where you're going to place your stethoscope on the posterior lung fields, okay? So let me back up for a second, because I didn't go like in the order. So when we are performing our assessment, right, for the respiratory system, we want to inspect first, okay? So we want to look, and what are we looking for?
Barrel chest, coloration of skin.
Yes, symmetry, right? So maybe they're kind of lopsided, barrel chest. So those are all the things that we're going to be checking for, right? And so after we finish our inspection, what's the next step? It's actually, so the way that it is set up, something that you need to know, right? Inspection, percussion, palpation, auscultation. The only system that's different is going to be the GI system, because we will inspect and then we will auscultate, and then we will percuss, and then we will palpate. And so that's kind of tricky, but the GI system, once you start poking around, you're gonna change the sounds. So that's why you auscultate before you start that palpation, okay? All right, and what's our next system? I just want to mention it to you. So as far as your bags go for this class, you can bring you're not necessarily the whole bag anymore, because I'm happy everybody has their bag, but your stethoscope, your blood pressure cuff, and I think that should be, if you don't have any tuning forks or anything like that, and of course your pen light. So you can bring those. You don't necessarily have to bring the whole bag, but leave it in your vehicle, you know, if it's safe to do that. Okay, so that's one of the things that you're going to look at when we are percussing, right, on page 419. It tells you how we're going to percuss. Now, when we are percussing, right, we're going to place our non-dominant hand over that field, and we're going to use our dominant hand, that middle finger, and we're going to tap the first knuckle on our middle finger, okay? And so that's what we're tapping, okay? That is percussive, okay? All right, that is percussion. So that's the way that we do it. So on page 419, it talks about resonance. And that's when you have this checklist, because we're eventually going to go to the checklist, but I want to kind of give you a little bit of background. Resonance is going to be what we're looking for, okay, in healthy lungs. Okay, hyperresonance, you see, you know, if you notice the way this book is set up on the side, the right, it gives you the abnormal findings, right? So you need to know the normal first and then the abnormal. So hyperresonance, I'm thinking that that's emphysema, right? Because their lungs are hyperinflated. It's like a balloon that's really stretched out. Now, dull lung sounds, that makes me think that there's an abnormal density in the lungs. Maybe there's a tumor. Maybe they have pneumonia or pleural effusion, might have built up of fluid, or even atelectasis, which is the collapsing of the lung, okay? Crepitus, that's gonna be that coarse crackling sensation, right? So in a patient with subcutaneous emphysema, it's kind of like, I love what Kathy said, you know, that bubble wrap, that you kind of crack it. That can happen in a patient that has a chest tube, okay? And that's more med-surg, but I'm just trying to give you some context, okay? Okay, so those are the lung feels, so on and so forth. That's the percussion, the breath sounds. I didn't really mention this during lecture, but the breath sounds, and I'll probably have to put it into Canvas as just an announcement. As far as the breath sounds, when we think about when we're listening to the upper breath sounds, those are bronchial, right? And then broncho-vesicular when we're midway, and then vesicular lung sounds are lower, okay? So just to be familiar with that, okay? And the round thorax and the infant. The other thing that goes with this, right, because the way this book is set up, it talks about subjective information and then objective. So subjective, this is where you can ask the patient, do they have any history of smoking, any lung trauma, do they have asthma, have they had any injury, right? And then the objective is, of course, what we see, okay? So that's just kind of a quick down and dirty of some of the things that you're seeing here. When we look at page 433, this is going to show us some abnormal findings. Well, we kind of talked about some of these already, right? So the normal adult on table 19.3, and we're on page 433 in the Jarvis book. We have, that's a normal adult for comparison, because you always look at what's normal and then you will see, oh, that is abnormal, right? Now the barrel chest, we've talked about that. That's going to be the COPD patient. Pectus excavatum, okay? So this is funnel breast. And I think I need to show you an actual person, because you will actually maybe appreciate it more if you see a real person. And as well as the pectus coronatum, which is sometimes called pigeon breast. I had a student one time, during COVID, I had some online classes, and he said we were doing, I was teaching anatomy and physiology, and he pulled up his shirt and he was like, yeah, I have pigeon chest. And I was not expecting him to do that. I was like, well, this is a great learning opportunity, right? Okay. So, it looked like it was really painful. That's not, okay. That's the funnel breast. So let's do the funnel breast first, because this looks like funnel breast, right? I'm gonna turn it around, Jasmine, so you. Here we go. This is a great, so one is in and one, oh, you can't really see it at all. All right, let me just get the light. I think you get the idea. Can you see? So your funnel breast is kind of like, okay, it's like a funnel going in, right? The pigeon, have you ever seen pigeons? They kind of walk like this, right? With their chest all stuck out. And so that's what we're talking about with that. Okay, the pigeon breast, okay? I want to say that he had that funnel breast, but yeah, I was totally surprised when he pulled up his shirt and showed that to us, okay? Some other things to think about is scoliosis and kyphosis, right? So scoliosis is the lateral curvature of the spine. I'm on page 434. Kyphosis, so scoliosis, and let me just mention that it's going to be more frequent in females, and it's usually found in adolescents. Kyphosis is going to be in your geriatric patients. Right, and I'm concerned because that actually alters their center of balance, so they become a fall risk. Okay, lordosis is a normal finding. It's a lower curvature of the spine. It's a normal finding in your pregnant patients, right? Because they have to have that curvature to really support that protuberant or that pregnant abdomen, right? But so those are kind of musculoskeletal, but as far as breathing, right, scoliosis, kyphosis, that could affect the breathing. Okay, there are different kinds of breathing patterns, respiratory patterns. And I'm sorry, I did not turn you around, Jasmine, so you could see.
Yes, ma'am.
Okay, let me just, okay, so you can kind of see what we're talking about here.
I can see it. Yes, ma'am.
Okay, perfect. Okay, so lordosis, kyphosis, scoliosis. Lordosis is more musculoskeletal, but I always bring these three up together just because you have to know the difference. So there are different kinds of respiratory patterns. You have to know the respiratory rate for adults, right, is going to be, this book says 10 to 20. Okay, sometimes you'll see 8 to 20, right? Okay, so what you see here is the actual pattern, right? So it's kind of like an EKG, but it's going to be for your breathing. So if the patient is sighing, right, you have that, and then you have tachypnea, that's the rapid shallow breathing, and that's really fast breathing. You have bradynypia, that's your slow breathing. Cheyne-Stokes respirations. So I just want to show you Cheyne-Stokes respirations and Kussmaul breathing. Cheyne-Stokes. Yes, that's not good. Sometimes you can hear it called death rattles. Okay, so Cheyne-Stokes. This is a good, okay, let me go to this.
Good morning, everyone, and welcome back. Today we'll be talking about Cheyne-Stokes breathing pattern. It can be caused by anything that causes cardiac failure, namely endocarditis and aortic. When there is cardiac failure, the blood flow is disturbed, This causes irregularities in the carbon dioxide levels, which in turn affects the breathing cycle of the brain. We see it mainly in deep sleep or comatose patients. James Stark's breathing pattern is described as a period of apnea, followed by gradual increase and decrease, and another episode of apnea. And here's how it sounds like. In most cases, treating the cardiac cause resolves the quality. But if it persists, however, CPAP can be tried.
Okay, why she has a long period of apnea, okay, doesn't she? Okay, all right, so that's your chain Stokes. Let me just show you who's small.
Today we'll be talking about Shane Stokes breathing pattern.
See if they have one.
It can be caused by anything that causes cardiac death.
So,
Welcome back. In this video, we'll be talking about alopecia areata.
okay. So let's go to who's small. This will be the last thing I think. Start getting things on.
Welcome back. In this video, we'll be talking about alopecia areata.
Oh.
And we'll
Inside Health and Rehabilitation Center, we turn setbacks into comebacks.
My stroke was totally unexpected.
It was really tough. All of a sudden, I had to make a lot of decisions.
Good morning, everyone, and welcome back. Today we'll be talking about crossmotor breathing pattern. It's caused by acidemia and anything that causes acidosis, mainly respiratory failure and diabetic ketoacidosis.
So I will tell you, there is a test question about pH. And it's a pH of 7.25, right? So a pH of 7.25, and the patient, I think, had respiratory acidosis because the normal range for pH is 7.35 to 7.45, right? So if the patient has this, we're looking at respiratory acidosis, okay?
This is the shape of.
Let's go back.
This is anything that causes acidosis, mainly respiratory failure and diabetic ketoacidosis. This is the shape of normal breathing pattern. Low frequency waves with low amplitude. Cosmos breathing pattern is high waves or high amplitude with high frequency. So it's basically a rapid succession of maximum inhalation and maximum exhalation. This is very effective in eliminating carbon dioxide. And here's how it sounds like. Carbon dioxide in nature is acidic. So whenever we have an acidic state, the next logical thing would be to eliminate the carbon dioxide to decrease the acidity. This is called the washing out of carbon dioxide. To treat it, we have to resolve the acidic state, thus eliminating the need to wash out carbon dioxide. For DKA, we use insulin, normosaline, and potassium.
I'm gonna pause that, and I'm sorry, I'm on med-surg base, but like you definitely need to know that. Maybe not for this class, but you gotta know this for med-surg. So please know that. We have this patient that has DKA, diabetic ketoacidosis, right? This is their blood sugar is not controlled. We're talking about patients that have insulin of like 500, 600, right? So insulin, normal saline, that's NS, and potassium, okay? So put that in your pocket for next term, okay?
For metabolic acidosis, we use bicarb, and so on.
All right, so let me stop here because now we're just gonna get to the hands-on, okay? Because I'm gonna stay too much focused on the other things, because I want you all to be able to work together and do your assessments, okay? All right, so I'm going to demonstrate, and I'm gonna go through the checklist, Okay, and I want to actually, I'm going to, after I go through this, I'm gonna break you up with your partners. And I'm gonna go run upstairs and get some alcohol wipes so you can actually clean your stethoscopes before you start listening to each other, okay? Because that's gonna be important, all right? So let's go step by step, and I did not email you the sheet, Jasmine. I'm sorry, I went back there and I did not email it to you.
I can take a picture of it and send it.
Oh, perfect, thank you, that is great, okay?
Thank you, Nicole.
All right, let's see, can you see everyone? All right. So introducing
Yes, ma'am.
okay, excellent, thank you. So introducing self-perform hand hygiene, and my goal is to let you all out as soon as we get both, your partner and you go through this, okay? So introduce self-perform hand hygiene, identify the patient, right? So you can say, hello, my name is Colleen, I'm gonna be your nurse today. Is it okay if I perform this assessment on you? I'm going to perform a respiratory assessment, right? Well, I'll check the R band, assess for allergies, provide for privacy if somebody's in the room. Is it okay if your loved one stays in the room while we perform this respiratory assessment, right? Now I'm going to assess the level of consciousness, and that's what we've done before, right? But this is all part of the general survey. So is the patient alert to self, time, place, situation, right? Where are you? Who's the president? What did you have for lunch today, right? Those kinds of things. So the patient appears to be alert and oriented times 4 and is in a pleasant mood. Okay, now if they're not in a pleasant mood, you can say maybe they have a flat affect, meaning that they're not showing any emotions, right? Or maybe the patient appears to be sad or distressed, right? Okay, so we're gonna assess the pain, always assess the pain, 0 to 10, 0 being no pain, 10 being the worst pain ever. Okay, do they have any mobility aids, any oxygen, right? Especially since this is respiratory, any assistive devices. We talked about hearing aids, any glasses, right? All of those things we're gonna look for. Specialized mattress, SCDs, those sequential compression devices, right? We're gonna ask those questions. They have any dressings, ostomies, IV, because that's a part of our general survey. So we're gonna measure the vital signs, right? So that's your blood pressure, your O2 saturation, which is really important, right, for respiratory, the heart rate, as well as your temperature and pulse, okay? So those are the normal parameters there. So now I'm getting into the focused respiratory piece. I'm gonna look at the patient. I'm looking at their rate, rhythm, and pattern. So we know for adults, our breath is rhythmic, right? It goes in and out. So what's different for infants? So it's faster, but that's not exactly what I'm looking for, but so ours is rhythmic, right? So what about infants? Yes, it's not a normal kind of smooth, because sometimes they'll breathe maybe twice, then they'll stop breathing, right? There's a period of kind of apnea, or they're not really breathing, and then they'll start again, right? So it's not really a smooth curve, and that's normal for them, right? That's normal for infants, okay? So that's what we're talking about, the rhythm, okay? So your breathing is at a regular rate and rhythm and unlabored. So if a patient has labored breath, they're really working hard, because breathing, you don't really think about it, you just do it. But if a patient is having labored breath, that's how they will present to you, okay? So your breathing is regular, right? And so I'm saying this to my patient, you have a regular rate and rhythm and unlabored, you are not using your accessory muscles. And again, the use of accessory muscles could be nasal flaring, the use of the sternocleidomastoid muscles, and their chest muscles. We can see retractions, right? Okay, we're also going to assess for clubbing, right? So you look at the patient's fingertip. Okay, no clubbing noted. Okay, you can say that. Okay, and clubbing is due to an excessive deprived oxygen state for a long period of time. Okay, okay, patient, do you have any history of lung trauma or lung injury, right? Maybe they got impaled in, at work or something, and they've got, one lung left. Who knows? Maybe they could be a coal miner. Maybe they're in the military and they're exposed to the burn pits overseas. Who knows, right? But that's what we're talking about. Smoking, environmental pollutants. So no surgeries noted. no trauma, no smoking, no history of asthma or pollutants noted, okay? Now you're gonna inspect that thorax, right, for symmetry and configuration. So I'm also looking to see if those anterior and posterior muscles are normal, right? And so that's where that pigeon chest or the funnel chest or the barrel chest can come into play, right? So we're looking for that symmetry. We're also looking for the use of the accessory muscles, right? A lot of times you'll see that in your asthma patients or your COPD patients, okay? So I'm gonna look for the posture. The posture is upright, right? So that's why I wanted to show you the kyphosis, the scoliosis, and the lordosis, right? Because now, okay, your posture is upright. Because if I'm kind of like this or like this, it's going to affect the ability of my lungs to expand, right? So I'm looking at that, and when you're doing this with your partner, I want you to verbalize this, right? Because once you become comfortable, right, when you get in clinical, your clinical instructor might want you to say that or they may not, but at least in your mind, you could be saying that, okay? All right, okay, posture. So we're going to now palpate the anterior and posterior chest walls for masses and tenderness. So when we talk about palpation, right, and I'm going to do it on myself, we're going to be pressing down, okay, palpating for any little areas of tenderness. And you really want to kind of do it in a pattern, right? So if you do it on the right side, you're going to go over to the left side, right? And so, oh, the patient may go like this, like, whoa, is that tender, right? And then you're going to ask some questions. Did you have an injury? Did something happen, right? Or any history of surgery? But you're going to palpate, and the patient may not say anything, but you'll notice if they're wincing or guarding or that kind of thing. So you're going to do it anteriorly and also posteriorly, right? So you're going to press, right? And always let the patient know what you're going to do and get their permission, but you always want to do it also in a systematic way, okay? So that's how you're going to palpate, right? And you're looking for any masses, okay? Or any areas of tenderness, okay? So you can say no tenderness noted, no masses or lesions noted. Then you're going to percuss, okay? So you will percuss, and so you'll go like this, right? I do it on the right, I do it on the left. I'm gonna go down, percuss, and then percuss, and then percuss. So you're gonna notice that zigzag pattern, right? I call it the zigzag pattern because you start on the right or the left, but you start on one side, you go to the same, right? But so on the same area on the left, because you're looking for symmetry. So I don't just go all right side and then go all left. If I'm here, right, in this area, I'm gonna go on the right, I'm gonna go to the same spot on the left. So I'm gonna percuss, right? Percuss, 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 okay? Anterior and posterior. And so your textbook actually shows you the fields, right? And I don't know if we have to be that specific, but I think it's good that you know that. And what page was it on? 425. Thank you so much. 425. So before, when I taught this at my other school, like we would make sure that they get like all of the spots. So when we're percussing, there's actually 5 spots, right? So like Siani said, we're looking at those 5 spots for percussion. And then that's on the anterior, and then on the posterior, where's the posterior? Let's see. Yeah, I think, okay, so 421. That's 419. Yeah, 419 is the percussion of the posterior chest. So it starts at the top, right? Right underneath the neck, and you can see that. So you see 1, and then it goes down the shoulders, and then goes down the shoulders, and then 2. So remember, we're not on the scapula. We're actually in between, right? Because we don't want to be tapping on the bone. We're not going to get the right sound. So notice we go all the way down, and you'll see spots 4 and 5, and then 6, then 7, and then don't forget the lateral. That's going to be your 8 and 9. Okay, that's going to be your 8 and 9. So that's with the percussion. Okay, and then you're going to auscultate all of your lung fields. And so there's 26 areas, right? When we combine both anterior and posterior. And so if you look on page 421, we are auscultating, and make sure we clean our stethoscope. That's what we're gonna get you the alcohol pads. You don't have any alcohol pads in your bags, probably not. We're gonna use, and so my stethoscope doesn't have a bell, but you're gonna use the diaphragm when you're auscultating, okay? When we're doing our respiratory assessment. All right, and so notice those fields. Notice that we start on the left, and then we go to the right, and then we come down, that's spot 2, and then we go to the left again, and then spot 3. So that is the zigzag pattern. That is how I want to see you assessing. And don't forget, again, when we're on the posterior, those lateral lung sounds, those lateral lung fields, okay? That's going to be super important, okay? So take a deep breath. And so let the patient take a deep breath when you're more so on the lower lows, because if you got 26, areas that you have to listen to, if the patient takes 26 deep breaths, they might end up passing out, okay? So just wait till you get to the lower lobes, okay? All right, and you're gonna check for the lung expansion, right? And so you're gonna place the hands on the back, right? And so this is the patient's spine, place the hands on the back, and then you're going to let them take a deep breath, and your hands should move, right, in a symmetrical way, okay? So that's what is going to happen there. And that's 14, step 14, and, oh, is that the end? Yeah, oh, it doesn't have the tactile fremitus on this, does it? That's when you do the 99. You'll place the hands on the back, and then you'll say, the patient will go 99, 99. Tac 418. 418, thank you. Because you could see that as a question in life. Tactile fremitus, where is it? Talks about, so, oh yeah, 418. Sorry, I didn't hear correctly. All right, so tactile fremitus is a palpable vibration. Okay, so 99, and I have no idea why we use 99, but I guess that creates a strong vibration. And so we're looking for that tactile fremitus. Okay, so symmetry. Okay, so see something. Start over and palpate from one side to the other. So every time you are palpating, the patient should say 99, 99, 99, 99, 99, 99, 99. Okay. All right. So the abnormal findings tell you that there's decreased fremitus, right? Because and this kind of makes sense. We say these words because as we're breathing, right, air is passing through our vocal cords, and that's how we actually make sounds, right? So if there's an issue there, right, decreased fremitus, that could mean that the air is not able to clear and pass through the airways. Okay. So that's going to be what we're looking for there. Okay, 99, 99, 99, 99. Okay, and I think that is it. Okay, let's go ahead and break up into partners, and I'm going to run up and get some alcohol pads so you can actually clean your stethoscope. But you can start with the first part, and I will be right back. Okay.
Tactile. So we have someone say 99. 10. Is it a 10 times? You got 1, 2, 3. All right, let's do this. Good night. I'm your patient. Okay.
Still, but come back for hearing.
Do you use any about devices? All the Say again?
Do you want us to actually do her?
No, you can just.
Okay, I'm gonna ask you one question.
Yeah.
Okay, so Jasmine, we are actually going through our lab right now. So do you have any questions?
No, I don't have any questions. I kind of saw everything that you were explaining, and then I know to read, well, it's a couple pages, but like 400 to like 415.
I think 418, 419, up to 421, but yeah, you know the chapter 19. So Micaiah
Chapter
said,
19.
yes, and Jarvis. So Micaiah said you can watch. I think her and Olusola are going to be together, and I'm going to be kind of watching everybody.
Okay.
Okay. Okay, awesome. Getting a sound residents. So it should.
I'm recording.
So.
And I'm watching.
A drum.
Hi, Jasmine.
Hey,
How are you?
I'm okay, thank you.
Well, good evening. My name is Olushola, and I'll be your RN for today. How are you? Awesome. Good. Thank you for asking. So, can I have your name, please? And I'm checking your hemband and your date of birth, please. Good job. What did you have for breakfast?
Oatmeal eggs.
Okay.
Yes.
That's nice. Good appetite?
Yes.
Okay. Do you have any pain?
No.
0 to 10, give me a number.
0.
0, that's good. So tell me where you are.
No.
And today's date, you got that right?
Yes, it's the 1st of November.
All right.
Am I doing this?
And you know what brought you to the hospital, you know the hospital, all those good stuff. All right. And I see you don't have any hearing aids, you don't wear glasses.
No, I do not.
Your mobility is good, steady.
Yes.
So it's gonna be how I move my dominant hand.
Do you have any weakness on any side?
No, I don't.
Because you want to hear the sound.
And I just took your vital signs, everything seemed good.
And it's the
The
middle.
blood pressure, the top number, 118, and the bottom number, 62. Yes,
That's
that's not bad. You don't have any pain, you did and your temperature was 97.6. That's all. Respiration, I counted as I'm talking. 16. So,
Okay. Thank you.
normal, your respiration and regular and unlabeled.
Yes.
So you're gonna go to big bag? Yes, okay, so you might have to.
Can I access your fingers, please?
Yes.
Alrighty, I see your thing, your nail bed, so.
Oh, now I'm gonna check it.
Friday, the color is nice. And it returns. And it returns, good. Can I see your copy is off? And you don't have any clothing.
And then you'll cross.
Have you had any trauma?
No, no surgery, because you don't have to
Pass out.
No smoke?
No.
And you're just down there to the lateral.
Exactly.
Now I will instruct your toes for strength. Anterior and posterior. She's recording this.
Okay, okay. Now, I know we're not doing this because we're not like baring our chest, but the best way to listen is directly on the patient's skin. Always clean the stethoscope in front of them, okay? And also clean your ear pieces too, so you don't introduce infection. Now,
I clean it, before, and you saw me clean, so.
I gotta feel it more on one side.
And I just want to breathe normally.
Okay, so I would ask them a question, so I would also compare questions, so say, and you have to also remember added. So that might absorb some vibration, so, right? So if that's what I'm adding to the report, that makes sense, or okay, that doesn't. That's why this is.
Yep. You'll be my patient.
And I'm gonna listen to you.
Okay.
Let me hear you. I'm like, on the hot, the upper.
Yeah. And then you're gonna move your hands down. Yeah, well, and then there's your always gonna be in little space. Think about pulling catheter insertions. You're in all in their space.
This is
That is percuss. That's a real palpate is like this.
feeling,
Yes, press it. Okay.
and I'm gonna pitch this one and back. Okay? Tell me if you feel anything.
That's how you're patient.
Ready.
What, third?
And my reach. Can I do the back?
So, yes, is it this to this, and this to this, or this?
Yes, the second.
This,
Yes.
this,
And
this.
Yes.
You don't go all down, then go around.
No.
It's this.
So you go from here
Yes, because you're comparing
here.
the right side to
To
the
the
left
left,
side. Right
then down
side
here
to
to
the
over
left
there.
side, right?
I'll do
Okay,
it
and
again.
will be for symmetry.
I'll do it again.
And that's the zigzag pattern. that I'm talking about.
Any pain?
And that's good technique, nice. Right.
Slowly. I just want to make sure it's also recording.
Okay.
And if you want, you can kind of turn around so she can see it. This way. Yeah.
Let's lift the chair.
Yeah,
I'll
so-
sit it.
Yeah, and then put the chair to the side so your back is visible. Yeah, there you go. Oh, shoot. Okay, first.
Yeah. Tell me if you have any pain, okay? Or if
That's
there
very
is
good.
any tenderness.
Okay.
Can you see that?
Yes, ma'am.
Okay. All righty, good. And that was-
Okay, so if they're a smoker, or they used to smoke, ask them how can they smoke and how they go to stop smoking. Good. That would, if I were to patient stop smoking, their lungs can actually heal it, right? So that's a good thing.
I can feel it.
You can?
So do you
But no
always-
tenderness?
That's great, you're doing great.
You always have COPD when you get it.
So it can be managed, but COPD is a
Sometimes
chronic
touch your booty area.
condition. Yes. And so then that's right. And so not just
And now I'm gonna
people that are exposed to environmental contaminants or those that have like, exposed to cigarettes.
Just breathe normally, okay?
Okay, I got you.
There will be nothing okay.
Yeah.
So it's gonna be.
Yeah, so right here, it's gonna be, because her scapula is right here, right? So it will be right here, and then, yeah, so this is actually a great, the sports bra is a great kind of marker, because that's what we're going. Okay, fantastic.
Any tenderness? All right, good. Started from here to here, to here, to here, and then back.
Yes, that's
That
okay.
one is, is here,
And
I think
any of
it's that.
When you have,
Is it one?
what are you looking for again?
any masses or tenderness, right? So sometimes the patient might have a lump here. But it means- And that's an abnormal. Also, on dullness, like, I think I was telling that group, if you percuss over the liver, you're gonna get a dull sound, but that's normal because it's a
Oh, I
dense
see.
mass.
I'm
If
sure I
I
know.
get a dull
That is
sound
when I do the
over the
big
lump,
that
that's
you see.
concerning, that might be their
So I'll do
mass.
your back first.
Right?
Thank you.
You're welcome, all right, great job. This was one of the easier assessments.
I'm doing the auscultation now.
Okay.
And that's when I do the zigzag.
Yes, that is correct.
So don't you go to the zigzag bar?
You do the zigzag in general, because you're, yes, because you're measuring symmetry, right? It's the left side and the right side, yes. Yes, yes, that is correct, and don't forget the lateral, right?
I'm gonna listen to your bed sounds, okay? And just tell me if anything is, bothering your. And breathe normally, okay?
Taking pictures, guys. My phone is like a forehead.
Hyper, that's hyper. Oh, that's like, don't forget the sign-in sheet.
Oh yeah, we just had training that we don't actually have to do the sign-in sheet, actually. We just have to do the roster. And I have, of course, I have to update it in campus link. Yes. Yes, and that's the placement of your stethoscope, yes. So you can start, one, two, one, and that's two, 3, 4, 5, 6, 7, and then 8, and I think there's 9 and 9.
So it's gonna be 18 for this one.
Yes, that sounds
It's
right.
right there.
And when you get to down here, that's when she can start taking the deep breaths. All right, good night, ladies.
Good night, y'all. Drive safe.
Good night.
Thank you.
I can show you the phone now. So this is the button over there. That's the silence. This is that I'm listening now, just so I'm getting. So here's the.
Whatever is pointing.
Yes, but the ones that school gives you, yes. Yeah.
Oh, shoot.
The diagram is.
I don't hear it when I turn.
Yes, yes. Okay, excellent. Did you prefer us to write that? No, whatever you.
That gave me 12 to put it back. Miss Polly, that gave me 12 to put it back.
Okay, okay.
Here,
Mhm,
here,
mhm,
here, here.
mhm. A little bit more, because this is probably right over her scapula, so come in a little bit more. Okay, but you get the idea, right? That's the most important thing. Now, when you go to the doctor, for real, they're not doing 26 lung fields. I'm gonna tell you right now, they're gonna probably
Yeah,
do
just say
6. Yes, but of course, they're seasoned and know what they're looking for. Now, if they hear something that's abnormal, then they're gonna
Yeah.
do a little more.
Yeah.
Yes.
Yeah.
Yeah, you got it. Mhm.
Yeah.
Good. Mhm. Mhm. Mhm.
And now I move. a little.
Yes. Mhm.
Okay, good.
Okay, good. And so the big thing is, don't forget those
I
lateral.
get that one very well. And that's when she keeps breathing.
Yes. Because, and why do you think that is? If a patient has pneumonia, a lot of times that fluid is at the base of the lung.
Of the, yeah, especially the posterior.
That's right, that's right. You don't mind if I take some pictures now?
And every time you feel my hand move, go ahead and say 99 for me, okay? Okay. 99. Right? Cool. Okay, good. 99. 99. 99.
And now getting to the boobs area, I have to.
Yes, and if you, that's a great question. If you have to lift the patient's breast, don't cup anybody's breast. Or you can ask the patient to lift their own breast if they're able to, but yeah, don't be cupping anybody's breast. Yeah.
Thank you very much for the. Hello, my name is May.
How did it go? Okay, fantastic. Jasmine, did you have any questions?
Good job. No, I don't.
Oh, yeah, the 90. Why did we say the 99?
That's at the end, and I'm sorry it's not on there, but you can do that at the end if you're feeling for tactile friendliness. So you'll start at the top right here, right? And she'll say 99.
You say 99?
99.
His team that do you have any pain from 0 to 10?
Do you feel it? Yeah, okay. And it's symmetrical?
Symmetrical.
Okay, yes, excellent.
And you can turn it around.
Good job.
Thanks.
For medical device.
Oh, turn this way.
Exactly.
So you can take your vitals, okay? Then.
99.
I'm already assessing.
99.
Do we go over the boobs though?
I would just go like right here, like, but not necessarily here, and maybe underneath.
99.
You have any
99. 99.
or recent surgery?
99.
Oh, right.
Thank you very much.
Okay. This is my second. I'm so sorry.
We can stop it.
Okay, what did you say last about that, there's a.
That's down.
We should be fine. Just record it for me. And then I can record, I mean, if you want me to.
Yeah, you can do it.
Well,
You want your-
and you're gonna be looking for, cutaneous emphysema. I think that's what, and that's the popping sound, right? So that some will find you in the beginning, but if they have a chest for a while, you don't want that crackling sound. That's subcutaneous.
That's not.
Is how long? All right. Okay, so Jasmine, we're gonna end this recording. Did you have any questions?
No, ma'am.
All right.